So, dear colleagues, ladies and gentlemen, welcome to APAGE-ISMIVS webinar episode 2. It is my great pleasure and honor to participate this webinar as a chairperson. So first, I would like to introduce all the chair and speakers of this episode 2. Co-chair is Professor Angela Sison Aguilar from Philippines. First speaker will be Professor Philippe Descamps from France. Next, Professor Chii-Ruey Tzeng from Taiwan. Then Dr. Jordi Rodriguez from Spain. And maybe finally, Dr. Wei-Chun Chen from Taiwan, as scheduled. So will you let me invite co-chair Professor Angela Aguilar to give some remarks? Please start.
Thank you, Professor Osamu. I would like to introduce the chair of this very important session, and I'd like to thank the organizers also for giving me this opportunity to participate. To introduce the chair of our session, Professor Tsutsumi Osamu is a professor of the Graduate School of International University of Health and Welfare. He is the director of the Sano Hospital in Japan, is an auditor and past president of the Japan Society of Gynecologic and Obstetric Endoscopy and Minimally Invasive Therapy. He was the past president of the Japan Society for Fertilization and Implantation and the past president and past Congress president of the Asia Pacific Association for Gynecologic Endoscopy and a president of the Obstetric and Gynecologic PRP Treatment Study Group. So I'd like to invite and yield the virtual floor to Professor Tsutsumi to introduce our first speaker for this evening. Professor.
Yeah, thank you for your kind introduction, Professor Angela. I now invite Professor Philippe Descamps. He is a professor at University of Hospital Angers, France, and director of International Relations Committee for CNGOF, and vice president of SCGP, France Society of Pelvic Surgery, and also FIGO executive board member. And he has numerous publications listed here. So will you please start, Professor Phillips?
Thank you very much, Mr. Chairman. It's a real privilege for me to be here today and to introduce this very important webinar. I put the first slide on. Is it working? Is it okay? You have the slide?
Yes.
Yeah, okay. Okay, so as I said, it's a real privilege, and I'm involved in this HIFU experience since more than 2 years, and I would like to thank, of course, the company, and we're working very hard to make the promotion of this new technique in France. So as an introduction, it's a very prestigious webinar and very well-known speakers today. I just would like to say that it's a major evolution for the treatment of myomas and adenomyosis. Okay, I don't have the next slide. I'm really sorry.
Take it easy.
Okay, it's working. So I'm living in the western part of France, in the Loire Valley, and for those of you that came to France, it's a really beautiful place. So of course, we all knew this evolution of skipping from conventional open surgery to laparoscopy and then to HIFU, which means no surgery at all and no scars. And of course, we were all involved in laparoscopic procedures, but now it's a very, very new adventure for us. Fibroids, you know that fibroids is a major concern for women. And in France, there's a difference between Caucasian women, white women, and Afro-Caribbean women and Asian women. And there are more fibroids among Afro-Caribbean women, which is 10% of the population in Europe. And the estimation is that the fibroids will be symptomatic, which means we'll need a treatment in 33% of the cases, which is, of course, a huge concern for women and for doctors. And it's in worldwide, it's the #1 indication for hysterectomy in France. Okay, it's a bit slow, but probably the computer or the website or anything. Sorry. I'm waiting. I don't know what's happening. Do you hear me here? Yes? Okay, so I'm sorry, it doesn't work. Maybe the internet connection. Okay, do you hear me? Yes, is it okay for hearing?
Yes.
Okay, I'm pressing the buttons and I think it will finally work. So the message is we are, you know that there are more than 227 HIFU centers worldwide, and in Europe, in my region of the world, there are HIFU centers in Spain, of course, and we'll have the opportunity and the luck to hear Jordi Rodriguez after. In England, in Germany, and we are working very hard now to have the reimbursement in France from the Ministry of Health, and I'm very optimistic that this will it will be a success. I'm sorry for the slides. And of course, HIFU is a major indication for fibroids and adenomyosis. And it means no scar, it means one-day procedure, it means no complications, and it's very important. We all know that there were in 2019 the NICE recommendations, and there's been a price published in December 2020, which was £4,000 for a procedure. And of course, those recommendations are based on the literature. There is a huge literature analysis, and it's very important worldwide to have those recommendations. Maybe the main message today is to say that, I'm so sorry for the slides. I think it's the internet connection. The main message is to say that it's a major evolution for women because of there are no scars, no complications, and also it can be of importance in the concern of adenomyosis and fibroids. Before an IVF treatment, and it's a real new point to stress on, and the following speakers will speak about this. And it's a possibility to have an HIFU treatment before IVF procedure and before fertility treatments. So this was my lecture. I'm really sorry for the slides, and I wish a very good success to this very important webinar, and I keep connected for any questions for France and Europe. Thank you very much.
So thank you very much for your opening remarks. It was interesting and instructive, especially for this meeting. So maybe next chair will be
Yes.
Professor
Chii-Ruey Tzeng. So allow me to introduce Professor Chii-Ruey Tzeng, who's very well known in our region and this part of the world. Professor Chii-Ruey is the founder and CEO of the Taipei Fertility Center. He's an honorary professor of the Taipei Medical University and a president of the Taiwan Endometriosis Society. He's a board member of the World Endometriosis Society. And he was the director of the Center for Reproductive Medicine and Science, Taipei Medical University Hospital in Taiwan, China, from 1994 to 2019. And he was our president, the Asia Pacific Initiative on Reproduction, 2016 to 2018. Professor Chii-Ruey has been an invited speaker in numerous grand conferences around the world with over 210 published peer-reviewed papers in our field of reproductive medicine. So I would like to yield the floor to Professor Chii-Ruey to give his presentation. Professor, please.
Thank you, Angela, and very nice to see you again, and also Professor Osamu Tsutsumi. Today, can I see my PowerPoint? Today, I will touch upon the challenges of the uterine fibroids and adenomyosis, especially in infertility field. Can I see my slide? Oh, there's some. Okay. Okay, so can you see? Yes? Can you see my slide?
Not yet, sir. Say, can you stop share and then start sharing again your screen?
Yeah. 17, 16. Can I?
There you go. Perfect.
Okay. Okay. Yeah.
Yes.
So the challenges of uterine fibroid and adenomyosis in fertility management. Can I have the second one? How can I?
You can use the small arrow at the bottom to advance there.
The fibroid-related infertility as following. First, it will increase the uterine contractility and also impair the blood supply in the endometrium and the myomectomy. And also, this fibroid will cause uterine cavity distortion and a thicker capsule. And also, they can impair the endometrial receptibility and the gene expression. And finally, the hormone of paracrine changes such as cytokine also increase. According to the figure, leiomyoma subclassification, you can see from 0 to 8. So that means some are some mucous myoma, intramural, and 2 subserosa. And the degree, it depends on how much involved the intramural. So there's 1 and 2, the difference. And there are some systemic review of the uterine fibroid for all locations of the uterine fibroid. No doubt that will decrease. You can see the relative risk is much less in the clinical pregnancy rate, implantation rate, and ongoing live birth rate. So all are compromised in patients with all location myoma. And at the same time, you see the spontaneous miscarriage rate also increase. However, when the myoma is located in the submucous area, you even see the worsen in patient in respect to the pregnancy, implantation, and ongoing pregnancy rate. So the relative risk are even higher in those patients. So how the strategy to management this uterine fibroid? I think we can use different approaches such as uterine artery embolization or through vagina or through catheterization. Or we can use hysterectomy by laparoscopic approaches or hysteroscopic approaches. Or we can use MR guide focus uterine surgery or HIFU forever. And for the intramural myoma, type 3, 4, 5, and 6, if the size is less than 3 centimeters in diameter, we can wait, so such as expectant management. If the size of uterine fibroids are greater than 3 centimeters in diameter, we can use the medical treatment up to 3 to 6 months. This is to try to decrease the myoma size and induce migration of the myoma as far as possible away from endometrium. So you can, so if the size diminish, we can do the natural conception or IVF. However, if no reduction, then the surgery is recommended. Then we look at our hospital in a couple of years. We collect about 224 patients doing the hysteroscope. You can see about 132 patients, which is 58% with abnormal uterine cavity, with some abnormal pathology, okay? So, and then we further analysis these 132 patients, and then they, some are polyps, uterine synechia, septal uterus, but about around 9% are due to some mucus, some mucosal myoma. However, after treatment, you can achieve about 33% pregnancy rate. Then I will show one case. This is some mucosal myoma type 1. That means majority is location in the uterine cavity, 35 years old, secondary infertility, and with some mucosal myoma. So you can see here the size, okay, the size of uterine submucosal myoma around 2 centimeters. So you can see the big submucosal myoma. So we can use the hysteroscope to remove this submucosal myoma. And then 2 months after, 1 month after second look, you can see still there's some residual, okay, residual intramural during the second look laparoscopic examination. So again, I remove this one at this, 1 month later, and then after the third look, almost gone, you see, and the submucosal myoma turned out to be intramural, so almost clean the uterine cavity. Again, about 3 months later, the patient received the intrauterine insemination with chromate and gonadotropin dual trigger, and finally by IUI or AIH, she had a baby. No need for IVF. The other case is multiple submucosal myoma. You can see here. So still 2-stage approaches. The first one removed the majority of the fibroid, and then the second look still 2 small submucosal myoma remain. Again, you can see the tortuous, the blood vessel on the surface of the myoma. So you can see why the patient are easy to get bleeding. Again, the second look and remove it. So finally, almost clean. And the patient had 2 pregnancies and had 2 babies. And this is more complicated. You can see the tortuous, vigorous vessels, continuous bleeding. And this size around 3 centimeters during the laparoscopic examination. So again, I did the remove this submucosal myoma by laparoscopic approach. So you can see here, use electrocautery. This is a flexible laparoscopic removal of the, so you can cut the majority of the submucous myoma and remain small portion of the myoma in the intramural portion. Quite big, yeah. Okay. I'm sorry. Well, what's happened? Where can I cannot see. Sorry. Okay. So the second look, you can see almost all the blood vessels are shrink. And then because we disconnect the blood supply, it turned out to be smaller and with pale and in appearance. And then you can remove easily for the second look. And after 2 or 3 months, you see almost clean. And the submucosal myoma subside. And again, for those patients with intramural myoma, this is another second case. This is in the 33 years old woman, and she had a spontaneous pregnancy 3 months after myomectomy. So you can see this is a big 3 centimeter by 7 centimeter in size. So multiple myoma, and then we can do a myomectomy, and she conceived spontaneous 3 months after the surgery. So this is another intramural myoma, a 30 years old lady, primary infertility for 3 years, multiple intramural myoma, and she failed IVF once. And again, you can see this is a big anterior myoma posterior, and also this inside this fibroid, there are some cystic degeneration. So you can see after remove, you can open the myoma, cystic degeneration here. And after the surgery, I think the surgery is in February, okay? So 4 months later, she conceived. We can see last week, she came back with early gestational sac in ultrasound examination. So the management strategy for uterine fibroid, we have surgical approaches or non-surgical alternatives, such as uterine artery embolization or HIFU or MR guide focused surgery. And also we have different management by medical treatment. You can use transamine or IUD, progestin coated IUD, or selective progesterone receptor modulator, IU-486, or Gnrh agonist, antagonist. The majority of the advantages try to reduce heavy menstrual bleeding or shrink the fibroid or correct the anemia. But still, there are some disadvantages. For example, when you use the progesterone receptor modulator, sometimes, according to Jack Donay's publication, associated with some endometrial changes, so-called PACES. So still is very cautious. And also when you use the agonist or antagonist, still the patient can develop the bone marrow density loss. So, and again, now they have some oral Gnrh antagonists available now. But be aware, in the recent publication from New England Journal of Medicine, when we do the uterine artery embolization versus myomectomy, again, the myomectomy had a better fibroid-related quality of life. So you can see here, this myomectomy, this uterine artery embolization, and this is quality of life measurement, the questionnaire after 2 years. The higher, the better quality of life. So again, you can see patient receive myomectomy, the satisfaction rate is much better, it's better than uterine artery embolization. Now, I will switch to the adenomyosis and the ART. You can see here in patient with adenomyosis, this is the foci in the tissue. You can see there are longevity genes highly expressed, which is 62. So this is why patients with the adenomas are not easy to be cured, because the gene, they can survive longer. And then what is the mechanism that impair the fertility potential in patients with adenomas? Because local increase the estrogen, and this is increased estrogen can increase the peristalsis of the adenomyosis. and also induction of the tissue injury and repair, so-called TIAR, in the junction zone. And this, at the same time, the adenomas is also, they can down-regulation of those implantation genes, such as FOXO1A or HAXA10 integrin, as well as the leaf protein. And besides, they also increase the macrophage MCP1, natural killer cell, and CD60. All these will impair the implantation. And then we try to examine our patient. You can see here, this is the endometrial gland with hemorrhagic opening. You can see during the hysteroscope, you can see the hemorrhage spot opening on the surface of the endometrium of adenomyosis. This is why those patients are not easy to get pregnant. It's continuous bleeding and bleeding. So the embryo is not easy to implant. So you have to cure this pathology. And the image starting of adenomyosis, as you know, the MRI is much better than traditional vaginal ultrasound because the area under curve is 0.9 in MRI compared with the 0.8 in transvaginal ultrasound. So the correct diagnosis was easy to obtain and more often with MRI. So you can see the MRI is very easy to appreciate this widespread thickening of the junction zone with numerous high signal foci and a loss of the definition in the endometrial margin. So it's more easy to be diagnosed by MRI rather than transvaginal ultrasound. And there's numerous publications try to explain, especially for patients with IVF in patients with adenomyosis, they are decreased the ongoing pregnancy rate. So you can see here, there are 3 publications, and this blue bar is adenomyosis. Okay, so equally, the ongoing pregnancy rate is suppressed compared with control. See the control group with much higher pregnancy rate compared with adenomyosis. So we must do something for those patients. However, when patients receive downregulation with Gnrh or so-called pretreatment with prolonged Gnrh treatment in these 2 publications, you can see the pregnancy rate is almost identical with the control group. So that's very obvious and clear. Gnrh pretreatment may do some beneficial effect to those patients with adenomyosis for IVF. So we have one patient, she's 40 years old, secondary infertility for 10 years. She had anemia because the big adenomyosis and severe with antiphospholipid syndrome because a bunch of antibodies, and her CA-125 is very high, about 576. However, she reduced the CA-125 level to 34 after 2 months of the Gnrh pretreatment. So you can see here, this before Gnrh, the size is very big. You can see the size of uterus is 9.9, very big. However, after two months treatment, reduced the size to 7/6. So you can see the tremendous effect of Gnrh. And then we have some pilot study. We collect 10 patients, okay, 10 patients, age range from 39 to 40. And you can see the CA-125 level before Gnrh very high, 100, 200. After Gnrh almost returned normal range, you can see about 31, 20 again. And in addition, when you look at the uterine size, before Gnrh is very big, and after Gnrh they reduce 63%, 29%, 70%. So you can see the tremendous reduction of the uterine size after Gnrh, 1 or 2 months treatment, and 4 of them get pregnant, conceived. Then we do the following study. We collect 36 patients, received ultra-long treatment. That means 1 or 2 months Gnrh, the other 7 with antagonist treatment. The only difference is the outcome. You can see for ultra-long group, you can see the clinical pregnancy about 36%, but implantation and ongoing also ongoing pregnancy rate about 28%. When you look at the antagonist group, almost 0 pregnancies. And then because I think age is very essential contributing factors to pregnancy rate. So again, we divide those 36 patients, 2 groups, age under 38 and age over 38. So with 16 is the younger patient, 20 is a little bit old patient. The only difference is pregnancy rate. You can see when younger patient, you can have clinical pregnancy of 5–6%, implantation 25%, ongoing pregnancy 50% compared with the age over 38. So age is important for adenomyosis. And what is the potential mechanism of the direct effect of Gnrh on adenomyosis? 5 reasons. Number 1 is the Gnrh, they can reduce tumor size by down-regulation of the TGF-beta. Also, they inhibit inflammation by diminished IL-1 and the induction of the apoptosis by suppression of the BCL2 or increase the BAX gene. The number 4 is oxidative stress. When they receive the Gnrh treatment, oxidative stress much less because the NO also diminished. Finally, the angiogenesis also diminished because all the VEGF are totally suppressed by this treatment. And again, a couple of years ago, we published a paper in Fertility Sterility. For those patients with uterine myoma, also the Gnrh agonist prolonged treatment also, they can suppress all those genes such as MAP kinase, VEGF, or some inflammatory gene, proliferative gene, etc. So the mechanism of the Gnrh for the uterine myoma is very similar to adenomyosis. And then you can see the for long-term pituitary downregulation before the frozen embryo transfer for IVF also could improve the pregnancy outcome in women with adenomyosis. So you can see downregulation first, and then frozen embryo transfer. You can appreciate the implantation rate is much better than control. Clinical pregnancy 51, 22 for control, and ongoing also about 49%. So downregulation, very, very important. And again, some meta-analysis, you can see a lot of publications showing the clinical pregnancy rate is much, much compromised in adenomyosis compared with control. You can see the clinical pregnancy only 0.2. And besides, they increase the miscarriage rate. You can see here in patients with adenomyosis, the miscarriage rate is around 2 times higher. You can see 2 times higher in patients with adenomyosis compared with the control. So again, for those patients, if the CA-125 is big and is high and big adenoma, sometimes radical resection of adenomyoma tissue is necessary. And Dr. Osuda, they already developed a so-called triple flap methods. The first one is cut the uterus, entering the uterine cavity, and remove the both sides adenomyotic tissue, and carefully, meticulously repair the endometrium, and then triple flap method to repair the the uterine myometry. And most important is after the surgery, see, we usually do a second look hysteroscope. You can see still some residual adenomyosis here. So you still need some surgery or need a Gnrh following treatment to remove. And then the patient can have the pregnancies. And so that is the successful pregnancy after conservative surgery for morbid or malignant adenomyosis. So you can see after the surgery, there are variable pregnancy outcome from 16% to 6%. But however, there's a large group from Japan. You can see 100 patients, and pregnancy rate can reaching 41% if age under 40. Still, age is very important. However, only 3% if age over 40. So again, you can see the importance, the age, and the probably size, and the pre-treatment or not with Gnrh or not. So for those patients with poor responder, sometimes we consider this downregulation, the side effect. So again, we can use the segmental IVF approach or adenomyomectomy. So depend on the patient's situation, depend on whether the patient is normal responder or poor responder. So that's the final diagram for IVF in adenomyosis. If the patient or patients should receive Gnrh downregulation, if the Gnrh return to normal, we can do IVF for oocyte retrieval and do embryo transfer fresh. However, for severe adenomyosis, for poor responders, then we choose segmental IVF. That means we do the ovarian stimulation and the egg retrieval first, and then downregulation of the patient with the Gnrh until the CA-125 less than 35, then we do frozen embryo transfer. However, if the CA-125 is still big and the size is still more than 10 centimeters, then in between, we select adenomyomectomy. And then downregulation and the frozen embryo transfer. Okay, so that's my last slide. I was thanking my collaboration across the Taiwan, the whole island, with my previous physician assistant fellow and my lab and so on. Thank you very much for your attention.
Thank you, Professor Chii-Ruey, for an excellent lecture as usual. So we'd like to open the floor for questions. Please type your questions in the chat box. And let me fire the first question, Professor Chii-Ruey. You've discussed hysteroscopy prior to natural conception, AI, or even frozen embryo transfer. How do you prevent intrauterine adhesions from occurring after hysteroscopic procedure?
Usually, because only 10% of the infertile patients have some pathology, so 90% is normal. So usually I do routine office hysteroscope with 3 millimeters fibroscope to see without anesthesia. So 3 minutes, you can examine the whole cavity. So 90% will be okay, but 10% with some uterine pathology. So usually we need to do the septum resection or polyp removal or the submucosal myoma removal. You can use the yellow barrier, the gel to prevent adhesion. But the most important is technique. If you're meticulous, careful technique, usually there's no adhesion. Just I show you in my slide. Usually no. But if you are very concerned for adhesion, you can use the gel yellow barrier to prevent adhesion.
Okay, thank you. We have a question here from Mr. Qatar Iraqi Husseini. What is the posology of Gnrh? I presume he was referring to how much would you give for a segmental IVF, or in contrast, or an ultra-long protocol that will allow you to improve your pregnancy rate?
Very good questions. Okay. Normally, the patient receive 2 months, that's more than enough. Because after even the patient CA-125 is very big, more than 200, 300, after 2 shots, 2 months, usually can see the downregulation of CA-125 less than 35. So there are 2 criteria. One, if the patient, the uterine size reduced to 30 to 40 to 60%, then you can proceed IVF, or the CA-125 goes down to 35, you can go for IVF. If the patient, the uterine size, the adenoma is still very big, more than 10 centimeter in diameter, second, CA-125 cannot go down to 35, then we consider adenomyomectomy. So adenomyomectomy usually is the last option. The first option is try to medical treatment, Gnrh pre-treatment, and 90% of patients no more than 2 months. Yeah, believe me, they will shrink, and you see the size shrink about 60%. So easy to do the IVF, or use IUI, or do the natural conception.
Okay, thank you. What about when do you start HRT for segmental IVF? After 2 months, we don't wait for period because the period does not arrive after 2 months of GnRH.
Yes, yes. After 2 months, you see normal CA-125, the uterine size shrink to about 6 centimeter in diameter. Then you can apply the HRT for H34, and then usually the pregnancy rate is very high.
That's good. So we have another question from Olaric. Hello, Olaric. Do we need Gnrh agonist after adenomyomectomy? Will that be, Olaric, will that be a
Please, yes.
Agonist for IVF or for segmental? How would that be?
Okay. After adenomyomectomy, usually I do routine hysteroscope to see if there's any adhesion, or because sometimes we go into the uterine cavity, so you can create some adhesion or some residual. I just see there are some endometrial adenomas openings in the endometrium. So the subsequently Gnrh for about 1 or 2 months is necessary for adenomyomectomy. The second reason, reason is usually after 3 months, the uterine enough time to heal. So please wait until 3 months after surgery to any kind of IUI or to embryo transfer, etc. 3 months is very important.
Okay, thank you very much. That was extensively discussed, and we've had a very fruitful Q&A. So thank you, Professor Chii-Ruey, and we'd like to move on. I'd like to call our chair of the session, Professor, to please introduce our next speaker.
So before his talk, I'd like to introduce briefly Dr. Jordi Rodriguez. Since 2007 and currently, membership of the Functional Gynecologic Oncology Unit and member of the HIFU unit at the New Terrassa University Hospital, Spain, and 12 years of experience in the treatment of uterine fibroid and other benign pathologies with ultrasound-guided HIFU. More than 850 procedures done between 2008 and 2020. Since October 2019, membership of the ESG Working Group on Non-Surgical Ablative Therapy on Benign Uterine Disease. Speaker at various courses and congress in gynecological endoscopic surgery and ultrasound therapy, both national and international, with the publication of some articles. So please start talk. Topic will be HIFU and fertility. Dr. Jordi, please.
Hello, can you hear me?
Yes, please start your talk.
Okay, I have some problems to share my presentation. Excuse me. Sorry. I don't know why I cannot to share my presentation in this moment. Oh, sorry. Okay. Okay, I think it's going to. Okay. Perfect. Sorry. Okay, thank you very much for your kind invitation to this webinar to speak about HIFU and fertility. Okay, the first thing I want to point out about the uterine fibroids, apart from the fact that they are very prevalent and cause significant morbidity in women, is that there is enough evidence about their negative impact on fertility. And this infertility associated with fibroids occurs by different mechanisms that have been described by some authors, such as anatomic distortion of the uterine cavity, and increased uterine contractility, impairment of the endometrial and myometrial blood supply, and hormonal changes induced by fibroids, which could impair gamete transport. Okay, but on the other hand, we must also take into account the age factor, because as you know, the age remains the single most important determinant of human fertility. Modern societies have changed rapidly, and currently there is a tendency to delay childbearing beyond the age of 32 years, mainly in Western countries. And this situation, combined with the increase of fibroids with age, leads us to a new scenario, which is the large number of older patients with fibroids and problems conceiving. And the advances in new reproductive technologies cannot compensate for this issue. This is a serious problem. The effect on fertility impairment depends on the location of the fibroid. This is clear. There is evidence that patients with submucosal myomas and intramural myomas distorting the uterine cavity have the most significant impact. On the other hand, some authors support the idea that intramural fibroids greater than 4 centimeters, even without cavity distortion, may also negatively influence fertility. In fact, there are many studies focused on association between this type of fibroid and in vitro fertilization outcomes. In this line, some publications like this systematic review or meta-analysis conclude that this type of fibroids, even small size, over 2 centimeters, really impact adversely on IF outcomes. However, it also concludes that there is still no definite evidence to indicate routine myomectomy in these cases. We strongly believe that HIFU therapy, but its non-invasive nature, could be a good treatment option for these patients. But okay, it's something that we have yet to demonstrate with some prospective randomized studies. On the other hand, when women get pregnant despite the uterine fibroid, they are subject to specific pregnancy complications, such as premature delivery, placental abruption, placenta previa, and abnormal fetal position, and another complications. In terms of treatment, there is currently a large arsenal of available treatments, from classic excisional procedures to occlusive procedures, and of course, ablative procedures such as radiofrequency ablation and high-intensity focused ultrasound. Even though so much variety of treatments, nowadays myomectomy is still considered the gold standard for women with symptomatic fibroids who wish to become pregnant. Surgery to remove fibroids seems to improve fertility, especially in submucosal fibroids. Anyway, if you look at the literature, one wonders if that is really true. This is Cochrane review of 2020 that concludes that there is no evidence for a significant effect on the clinical pregnancy rate after myomectomy of an intramural or submucosal fibroid. This is not my opinion, it's published evidence. Nevertheless, there's enough evidence about complications associated with myomectomy, hemorrhage and blood transfusion, organ injury. It can cause pelvic adhesions that may increase the risk of infertility and cause a uterine scar, delaying the time of gestation and increasing the risk of uterine rupture. Okay, what can HIFU offer to these patients? Surely many of you already know that HIFU is an emerging and non-invasive technique for the conservative treatment of solid tumors. In 2002, Professor Wang reported that ultrasound-guided HIFU was safe and effective in treating uterine fibroids. In 2004, FDA approved HIFU for the treatment of uterine fibroids. In 2019, the National Institute for Health and Care Excellence approved HIFU technique and published a medical guidance on ultrasound-guided HIFU with evidence-based recommendations. In the same year, the SG Working Group on Non-Surgical Ablative Therapy of Benign Uterine Disease was created, of which our HIFU unit played an active role. Okay, according to the Focus Ultrasound Foundation, right now, over 128,000 women with uterine fibroids have been treated throughout the world with great success. Okay, in respect of the therapeutic principles, the ultrasound waves are delivered by therapeutic transducer, and they travel safely through adjacent tissues to reach deep into the focal spot. Suddenly, a small area of selected tissue is heated between 70 to 90 degrees and is destroyed. Focal spot is guided by real-time ultrasound imaging. The safety of the treatment is based on its great precision to treat tumors. This is supported by several studies of pathological anatomy that demonstrate a coagulative necrosis with clear and sharp boundary between treated region and non-treated region. Okay, and this is the result of HIFU treatment. On the left, you can see the images before sonication, and on the right are images after treatment that show hyperechogenic changes at the top and a non-perfused volume of 100%, on contrast enhanced ultrasound and on contrast enhanced MRI. In relation to fertility, HIFU safely and effectively achieves ablation of uterine fibroids without damaging the surrounding myometrium, which conserves its biomechanical properties of tension and contractility. HIFU also preserves ovarian and endometrial function. We have some studies that show no significant difference between the anti-Mullerian hormone levels before and after treatment, with no amenorrheic patients after the procedure and with no symptoms suggestive of menopause after treatment. In this other prospective study from the last year, Melkozerova et al. Observed no significant changes in molecular and tissue markers of endometrial receptivity in women undergoing HIFU ablation for uterine fibroids. The objectives of HIFU ablation of uterine fibroids in women with gestational desire are, on the one hand, to achieve the inactivation of the hormonal and vascular function of fibroids. On the other hand, to shrink them in order to normalize the uterine anatomy. Both things seek to increase the chances of obtaining a safe pregnancy without complications of the surgery. Well, we already have several publications with good pregnancy outcomes after HIFU treatment, large series of 80, 100, and up to 130 pregnancies after HIFU with high gestation rates. The conclusions of all the authors are the same. Full-term pregnancies with a normal delivery and without complications are possible after HIFU, and there were cases of uterine rupture or abnormal placentation. Okay, I'm going briefly to talk about our experience with the HIFU technique and the pregnancy outcomes. And I take this opportunity to congratulate my team at the Mutua Terrassa HIFU unit in Barcelona for the recent publication of our work. In our retrospective study, we include 560 women with symptomatic uterine fibroids who underwent ultrasound guide HIFU between February 2008 and February 2018. 71 pregnancies of 55 patients have been obtained, which is, to our knowledge, the longest series of pregnancies after HIFU treatment in a Western country. The pregnancy rate was 34%, which is similar to or better than after laparoscopic or laparotomy myomectomy, and higher or lower than that after hysteroscopic myomectomy, depending on the study. Among the 71 pregnancies, there were 43 deliveries, including a natural twin gestation, 22 first trimester spontaneous abortions, and 6 therapeutic abortions for personal reasons. As you can see in this table, the incidence of cesarean section was low. It was 43%, which was much lower than in patients undergoing myomectomy or uterine artery embolization, or in those reported by other authors after ultrasound guide HIFU. Regarding the characteristics of 43 successful deliveries achieved after HIFU, the rate of full-term deliveries was 91%. Therefore, the rate of preterm delivery was 9%, only in 4 cases, which is lower than in the series of pregnancies with untreated fibroids or pregnancies following UAE. The mean birth weight of the 44 newborns was 3 kilograms. 7 of them were low birth weight infants, these that you can see here, except for the 1.4 kilogram baby who was born with a previously diagnosed tetralogy of Fallot and intrauterine growth restriction. The remaining newborns, 98%, developed well without complications during postpartum and breastfeeding. The complications detected during pregnancy were 1 case of first trimester bleeding, 1 preterm labor, 1 renal colic caused by growth of the myoma, 2 cases of placenta previa, and 2 cases of preterm premature rupture of membranes. The intrapartum and postpartum complications reported include 3 retained placenta with manual removal, 1 of which received red blood cell transfusion, 1 case of severe preeclampsia that ended in forceps-assisted delivery at 37 weeks, and 2 cases of emergency cesarean section for fetal bradycardia and for hemorrhage associated with placenta previa. It should be known that this series had no cases of uterine rupture or placenta accreta, which can occur after myomectomy or UAE. Regarding the clinical outcomes of the treatment in the 55 women who became pregnant, HIFU ablation was followed by substantial shrinkage of the ablated fibroids with significant symptom improvement. We must highlight that these results were achieved in women with a medium maximum diameter of treated fibroids of 6.4 centimeters and a non-perfused volume ratio of 76%, which is higher than that reported in most series of HIFU treatment. only 5 minor complications were observed. This in one patient, the 10-centimeter fibro treated was almost completely expelled from the vagina 6 months after HIFU ablation. Another patient had vaginal discharge of the treated fibroid 2 months after HIFU. One patient had first-degree skin burn, and 2 patients had self-limited hematuria. No major complications such as bowel or bladder injury or nerve damage occurred, and no patients developed amenorrhea after HIFU ablation. Then I'm going to present some interesting cases. This is a 30-year-old woman with a previous premature leva with hypermenorrhea and anemia, severe anemia, and secondary sterility. As you can see, she had a transmural fibroid of 10 centimeters. It is hypointense, very good case, and has low vascularization. This is a very big fibroid, but with 2 good characteristics to respond to HIFU. Okay, we achieve a complete ablation. You can see 100% ablated. And this is image, you can see the great non-perfused volume. MRI 6 months later showed a reduction in the size of the fibroid to 2 centimeters. Just then, the patient underwent a hysteroscopic resection of the remaining myoma fragment. And this is the hysteroscopic video after HIFU and surgery showing a normal uterine cavity. The woman became pregnant spontaneously 3 months later and gave birth to a healthy baby weighing 3.5 kilograms. This is a 33-year-old nulliparous woman with hypointense submucosal fibroid of 6 centimeters and hypermenorrhea. You can see the myoma occupying the whole uterine cavity here, type 0, type 1, with high vascularization, this on the right, and small areas here and here, small areas of low vascularization. Contrast-enhanced image immediately after HIFU showed a non-perfused volume of 100%. 6 months later, the myoma completely disappeared with restoration of normal uterine anatomy. This patient achieved 2 full-term spontaneous pregnancies that ended in uncomplicated vaginal deliveries at 38 and 37 weeks. Okay, a few words about adenomyosis. We know from different publications that adenomyosis is an important cause of infertility, and that treatment is a great challenge for the gynecologist. Adenomyomectomy is very aggressive for the uterus, and this type of surgery carries subsequent obstetric risks that we cannot ignore, or surgical risks. Okay, severe hemorrhage with subsequent emergency hysterectomy, and when the women get pregnant, it's possible the uterine rupture and some risk like this. The results from this meta-analysis show that HIFU is effective for the treatment of adenomyosis, reducing the uterine volume at 12 months, reducing dysmenorrhea at 3 and 12 months, and improving the quality of life at 6 and 12 months. Adverse reactions after HIFU were reported in 56% of patients, which were grade A or minor complications. There are still few studies on pregnancy outcome after HIFU treatment for adenomyosis, but the results are quite encouraging. In this study, 68 patients with adenomyosis who wished to get pregnancies were treated with HIFU ablation. 54 patients got pregnancy at the median of 10 months after HIFU, and 21 of them had delivered healthy babies. No uterine rupture occurred during gestation or delivery. Dysmenorrhea and menorrhagia in the patients who had pregnancies after HIFU were significantly relieved. In this other study from the last year, 93 patients with adenomyosis and infertility were included. 50 were treated with HIFU and 43 underwent laparoscopic excision. The most important conclusion of the study was that patients treated with HIFU showed significantly higher pregnancy rates and natural conception rates than those who underwent laparoscopic surgery. You can see here a pregnancy rate of 52% in the HIFU group versus 30% in the laparoscopic group, 40% of natural conception versus 80% in the laparoscopic group. As a conclusion or message to take home, uterine fibroids and adenomyosis can negatively affect fertility and increase the specific risk of specific pregnancy complications. And myomectomy and adenomyomectomy have some disadvantages that we have considered, especially in women who have decided to conceive. According to our experience, ultrasound guide HIFU therapy is an effective and safe treatment for uterine fibroids. Ultrasound guide HIFU makes it possible to obtain full-term pregnancies with few intrapartum or postpartum complications in patients with benign uterine pathology. And due to its non-invasive nature, it should be the first therapeutic option in women with uterine fibroids and gestational desire, with many disadvantages over myomectomy. And of course, we need prospective randomized studies to confirm these observations. And okay, that's it. Thank you very much for your attention. If you have some questions.
Yeah. Thank you for your beautiful presentation. We are very much appreciate your contribution. And
you're welcome.
Maybe first question from me. Cesarean rate in fibroid 43%, and adenomyosis you showed cesarean rate is 67%. Why there is some difference in cesarean rate in between fibroid and adenomyosis?
Cesarean, sorry, the
cesarean rate in case of fibroid, you showed 43%.
In my series, yeah.
Yeah. And adenomyosis 67%.
Yeah, after HIFU.
Yeah. After fibroid and adenomyosis, there is some difference. In cesarean rate.
Yeah.
Why?
Yeah. After cesarean rate after in adenomyosis after HIFU treatment is 67%. Okay.
Yeah.
It's a very good question. It's difficult to answer this question. And it's difficult probably because in the group of patients with adenomyosis, the incidence or the prevalence, the incidence of sterility is very high. And it's probably these patients, when they achieved a pregnancy after in vitro fertilization, is very difficult to achieve pregnancy after adenomyosis. And probably this group of patients wants to have a very safe delivery, and probably for personal reasons, these patients wants to have a shorter cesarean section to avoid some problems of the vaginal delivery. Perhaps, I don't know. This is a possible reason. But it's difficult to know why.
Oh, thank you for your explanation. And is there any question? So, okay. How many cycles? So
Yeah.
how many cycles of HIFU treatment required for adenomyosis? How about interval between treatment? There is a question. Yeah.
Yeah. But it's with one session of treatment is enough to have good results in adenomyosis. Yeah, only one time. Yeah, only one time. But and you can repeat this treatment 1, 2, 3 years after the first treatment if the adenomyosis recruitment is okay, appear newly, but for the first time we can treat in one session the whole adenomyosis. Yeah. And okay, we can, and the patient can get pregnant 3-6 months after treatment with no problems. Yeah. I cannot demonstrate this because we don't have studies, okay. But probably if we wait 3 months, 6 months is enough to get pregnant.
Maybe.
Yes,
maybe
I
another
can read.
Question, maybe for adenomyosis, do you use Gnrh?
Yeah. We use 3 months of Gnrh analogs before treatment. Yeah.
Okay.
In all cases.
Okay. So thank you very much for your beautiful presentation. We enjoyed your talk. Next, maybe chairing by Dr. Angela.
Okay, thank you, Professor Tsutsumi. I would like to introduce our last speaker, certainly not the least, to present a video on HIFU treatment of adenomyosis and myoma. He is Dr. Wei-Chun Chen, a visiting staff of the Department of Obstetrics and Gynecology of the Gynecologic Oncologist Group of the Changgung Memorial Hospital in Taoyuan. He's a member of the Taiwan Association of Obstetric and Gynecology and an associate member of the Taiwan Association of Gynecologic Oncology. He's in fact the director and member of the Taiwan Society of the Gynecologic HIFU Treatment and a member of the Taiwan Society for Peritoneal Surface Malignancy. His research interests are, of course, gynecologic oncology, surgical oncology, as well as chemotherapy. But his focus, and he will talk about it, is high-intensity focused ultrasound in gynecologic benign tumor. So I'd like to yield the floor to Professor Dr. Wei-Chun Chen. Dr. Chen, please.
Okay. Can everyone hear me?
Yes, Prof. Dr.
So,
Chen, you
is the
can.
shared video, can everyone see?
Yeah,
okay?
we can see you, but you're on presenter view. So maybe you can just share part of your slide.
Okay, okay. Okay.
Okay, correct. Go ahead.
Okay, hello. Good evening. I'm Dr. from Changgung Memorial Hospital of Lincoln. My name is Wei-Chun Chen. Thanks to APAGE, give me a chance to have a talk here tonight. My speech is the HIFU treatment of myoma and adenomyosis. I will also show the video demo. And this is the outline of my speech. And the HIFU is high intensity focused ultrasound. It's a non-invasive treatment for myoma. HIFU utilizes the physical characteristics of the ultrasonic wave, such as tissue penetration and focus ability. It can penetrate the abdominal wall and focus the tumor inside body. So the energy produced in focus area can destroy the tissue by coagulation necrosis. So this is a swine liver translation view. We can see HIFU at an acoustic channel and focus at the internal target to make the focus site turn to white color as coagulation necrosis without damage to surrounding normal tissue. So HIFU can make the swine liver to coagulation necrosis during HIFU ablation. From gross view of tissue translation, the treated area turn to white. Besides, under real-time ultrasound during HIFU, the coagulation necrosis area also turn to a bright sign we call grayscale change. HIFU can make cavitation reaction in the treated tissue. Cavitation can make a bubble oscillation reaction in tissue when the energy accumulation to a threshold limit. Bubble is pro and then occurred and make the local tissue coagulation necrosis. The post-NRI view can also see the necrosis part turn to non-perfusion area. The coagulation necrosis can make the local cell necrosis in acute phase and the delayed phase due to vascular destroy. Local cell apoptosis will also occur, and the dead cell debris was then cleared by the immune cell, that lead to tumor reduction. And our HIFU center, Chang'e Memorial Hospital, Taoyuan HIFU Center, located in northern Taiwan. So this is our HIFU center starts since 2015. We are one of the earliest hospitals to involve HIFU as a treatment of myoma and adenomyosis. Last year, we had treated 130 cases. The machine of HIFU we applied is Chongqing HIFU machines. So in our center, a standard HIFU machine with a meeting room and then observation room can make a good HIFU treatment, as well as HIFU teaching and training in our center. Here I will show you the size reduction rates in our center. We had calculated the data during 2015 to 2017. Since time limit issue, I will only add this basic treatment data here. There were 139 myomas and 124 adenomyosis in the 3-year data. The median myoma size was 8.4 centimeter, and the adenomyosis was 7.9 centimeter. The HIFU treatment duration was around 87 to 106 minutes. The sonication time was 923 and 744 seconds. Here is the size reduction rate by different examination timing. The non-perfusion area ratio after HIFU by NRI was 90 to 100%. The 3-month size reduction rate was around 50%. 12-month size reduction rate was around 60%. We can see even 48 months, the 4-year size reduction rate can be measured at 70%. So I would like to show video demo of myoma case here. This 32 years old lady had no pregnancy history, no operation or disease history. She had myoma diagnosed at least 3 years. She usually had dysmenorrhea, voiding frequent symptoms. The pre-HIFU lab data showed normal range of CA125 and LDH. That suggests the myoma was favored a benign lesion. So from the pre-HIFU NRI, we can see in T2 weighted image, the myoma was hypointensity. That means the myoma may be hypovascularity and the energy can be left for a long time inside. So the myoma was at the anterior wall and the size is 7 centimeters. From T1 contrast enhanced image, the lesion was hypointensity. Based on T1 enhanced and T2 weighted image, we can predict it may have good response to HIFU for such myoma. The feature of myoma ablation, since myoma has a capsule, the energy can be limited by this capsule and the accumulation. The intensity inside myoma, the accumulation energy can then make the general ablation. That usually use the concentrated high dose energy strategy for the myoma ablation. So we can see here is the Acl view of myoma. When we use HIFU to treat the myoma, we usually use the Acl view of myoma, and the Acl view can separate to several 5 millimeter phases. Then to ablation, we firstly choose the central largest phase. Under the HIFU treat view, we can image the myoma as a 4-quadrant view and choose the deep and the full side as the initial treated point to give energy, the yellow point. And after treating the yellow point, we can give high dose energy to the neighbor point, the brown point. That is the central phase, and after the central phase treatment, then we choose the neighbor phase to high dose energy treatment. We also treat the deep and the full side, the yellow point, then to the brown point. Then go on another side, neighbor to the central phase to high dose energy treatment. We also treat the deep and the full side firstly, the yellow point, and then the brown point. So usually after energy focus on central 3 phases, there is a great scale change as coagulation necrosis can be seen via real-time ultrasound. The coagulation necrosis area can even larger than the treatment core since the energy can extend about 1 centimeter from the focus target. So after concentrated energy given, then start to put energy to other untreated area by phase. We notice the most lateral 2 phases should be omitted since the energy can extend 1 centimeter from the focus target. So we need to omit the lateral 2 phases to avoid energy exposure to outside organ. Here, the reinforcement treatment was along the deep arc lining of the myoma edge with the same dose of energy giving. So here I show the video demo of the myoma ablation. First, we check the first treated point in a large central phase. We then use the balloon, like the picture, to put the balloon between HIFU probe and abdominal wall. It can make the focus inside the tumor. So besides, the balloon can also make compression to push away the bulb from the hyperacoustics channel. So after balloon setup, we then establish the treated phases. Then we use concentrated energy strategy to put the high dose energy to the central largest 3 phase firstly. Like we just said, we choose the central large phase, and then we started to treat the deep and the full side of the myoma. And first treat the yellow point and to the other brown point. After the central phase, we treat the neighbor phase. Like we just said, we also treat the deep and the full side. Firstly, so during our treatment, we can compare the picture. The left side is the pre-HIFU view, and the right side is under HIFU treatment view. And we can compare the two views, and we can see there is obvious grayscale change of myoma. The myoma getting much bright than treatment than untreated phase. So sometimes we need to take rest of the skin. So we can see there is cluster grayscale change can be seen during HIFU ablation. That is a coagulation necrosis sign of ultrasound finding. And we usually make a storage of the picture during treatment. So after cluster grayscale change was found, focus energy along the cluster area to expand the cluster change. So after the central 3-phase treatment, we started to put the energy to the other untreated phases to make the energy reinforcement. Also, the treated point was along the outlining of the myoma edge. Yeah. So during treatment, we need to notice the edge of the myoma, and is there any other soft tissue between the skin and the uterus? We need to avoid to the focus, to prevent the focus outside the uterus. And then when we treat the left lateral side, we need to make sure the left side limit, and to see is the left side is completely treated. So after the left side treated, we turn to the right side myoma treatment. The same as previous treated. We need to make the treated point along the outlining of the myoma. And every time we start to treat the phase, we need to measure how the distance between the focus to the myoma edge. Okay. So after the left side and the right side treatment, we can see the obvious grayscale change in the myoma. Then we remove the water balloon and make sure the internal grayscale change to see is there any other part of myoma still not treated. Also, we use the Doppler to make sure is there any internal blood flow inside the myoma. If there is still blood flow inside the myoma, we need to make a reinforcement of the energy. Of course, many countries use the contrast median to confirm is there any blood flow inside. But because in Taiwan, there is no legal contrast median indicated for gynecology tumor. So in Taiwan, we still use only very simple, the Doppler ultrasound to make sure there is no flow inside the myoma. So we can see this myoma has full of grayscale change without the internal blood flow. The blood flow only at the surrounding area. That's okay. So the cluster grayscale change found at 385 seconds of sonication. And the treatment finished at 850 seconds of sonication. No central flow after HIFU. The total treatment was 112 minutes. HIFU average power was 400 watt with total energy was 339,700 joules. So this is the immediate Gnrh after HIFU. Both T2 and T1 enhanced image showed mass as 7.2 centimeter with no reduction, with central non-perfused area ratio about 100%. So we can compare these patients pre-HIFU and post-HIFU Gnrh. We can see the central coagulation necrosis area with no contact flow into the area. So after 1 month follow-up, the myoma shrink to 5.8 centimeter. The volume reduction rate about 45%. And after further 3 months follow-up, the myoma shrink to 4.7 centimeter. The volume reduction rate is about 70%. Then here we introduce a very classic adenomyosis treatment video demo. This 42-year-old lady had one cesarean section history. She had no chronic medical disease, but ever received abortomy myomectomy in 2013. And her adenomyosis had been found for 4 years, and it makes her hypermenorrhea with dysmenorrhea. She had tried Visan and gastrin before, but both were not satisfied. She had elevated CA-125 as 96.3. So this is her pre-HIFU Gnrh. She had posterior adenomyosis size as 5.2 centimeter to 60.1. So this is her T2 image of Gnrh. We can see the myoma was a posterior extrinsic adenomyosis size as 4.8 to 7.7 centimeter. Her T1 weighted image showed hypointensity, so it can predict her adenomyosis may have good response to HIFU. So the HIFU feature of adenomyosis. Traditionally, adenomyosis can be classified as intrinsic or extrinsic by the junction layer near endometrium or serosa. And this is the intrinsic type. First is the intrinsic type adenomyosis. The adenomyosis part is near endometrium, and the extrinsic type adenomyosis in the figure 2. The adenomyosis part is near serosa. So since adenomyosis has no capsule like myoma, so it may easy to spread to area outside adenomyosis. So when we perform HIFU, we need to be careful of endometrium and the serosa lining during treatment. Usually, the intrinsic type was easy to, the energy when we treat the intrinsic type was easy to endometrium, and the extrinsic type was easy to serosa. So when we perform HIFU for adenomyosis, unlike myoma, we need to use average low dose energy strategy, and the individual reinforcement of energy after general energy application. So we also start the Acl view of Adenomyosis. Also, Acl view of Adenomyosis can be separated to several 5 millimeter phase. When we used to perform HIFU, we also choose the central largest phase. So we can see the HIFU treated view. Yeah, when we perform HIFU for Adenomyosis, we need to confirm the endometrium and the serosal lining. Well, after we confirm the endometrium and the serosal lining, we also choose the deep and full site as the initial treated point, the yellow point. Then after the yellow point, we put the energy on the brown point. So the same as myoma, after central phase treatment, we choose the neighbor phase to treat. Also treat the deep and the full side firstly, yeah. Then go on another side, neighbor to central phase. Also treat the deep and the full side firstly, then to the other neighbor points. So like myoma, then after treat the central 3 phases, we then started to put energy to other area, phase by phase. Also, we must notice the most lateral 2 phases should be omitted to avoid energy exposure to outside organ. So in other phase, we use the low dose energy to put to low point along the deep arc lining of Adenomyosis edge. So after put the every phase, every treated phase, then we perform a Doppler ultrasound to see if there is still any other blood flow inside the Adenomyosis. If still flow inside the Adenomyosis, we can make individual reinforcement of energy to treat the low internal flow. So here is the video demo of Adenomyosis. Yeah, when we treat the Adenomyosis, we can compare the Gnrh, and we need to measure the distance to skin to check the endometrium and the serosal lining. Then we use Doppler to check pre-HIFU blood flow of Adenomyosis. So we can see there is many soft tissue like ball between the uterus and the abdominal wall. So we also put the balloon to make compression. The balloon compression can push ball away from the acoustic channel and make our focus inside Adenomyosis. Yeah. So after compression, we can push the ball away of the acoustic channel. Then we started to treat the Adenomyosis. Also, we use average low dose energy strategy. We choose central 3 phases to give energy firstly. Yeah. So this is the central phase. Yeah. We also treat the deep and full side, and after the central phase, we go to the neighbor phase to treat. So during treatment, we can see the grayscale change can already be seen, but we also notice there's some bright tissue between the uterus and the abdominal wall. So when we treat it, we need to check is this only a bladder phase or some bowel involvement in our acoustic channel. So this is under the central phase treatment. Then after central phase treatment, we started to put energy to other untreated area This patient was started to make treatment from the right side. Also, we make the treat point along the arc lining of the adenomyosis edge. So this is still under treatment. So once we treat every phase, we need to confirm if this phase is near the edge of adenomyosis. So we need to confirm the right side limit to confirm if the right side already finished treatment. Now, after right side treatment, we go to another side, left side, to put energy on the left side. So this is the left side. We can see there is grayscale change compared with the pre-HIFU view. Yeah. So this view is confirm the left side limit to check if the left side of adenomyosis has already been treated. Yeah. Now we can see, compared with the pre-HIFU view, the general grayscale change can be seen. So after the left side and the right side treatment, we then remove the balloon to see if there is general grayscale change inside the adenomyosis. Yeah. So compare with the untreated view, we can see general grayscale change can be seen after HIFU. Then we use Doppler ultrasound to see if there is still any blood flow inside the treated area. If there is still blood flow inside the adenomyosis, we need to make low dose energy reinforcement. Yeah. So these patients, after HIFU, had cluster grayscale change since 492 seconds. We finished our HIFU treatment at 520 seconds. Her post-HIFU MRI showed of T2 and T1 enhanced image showed the adenomyosis size was 5 to 6.1 centimeter. The volume reduction rate is about 33%. The non-perfusion area ratio is 97%. Yeah, this is her compared to the pre-HIFU and the post-HIFU MRI. So we can see the HIFU, after HIFU, the non-perfusion area can be produced, but the energy was very close to the endometrium. So when we treat the adenomyosis, we also need to confirm if the patient had any pregnancy event and control the energy of the dose we give to the adenomyosis. So after the HIFU, this patient's total treatment duration was 125 minutes. The sonication time was 520 seconds. Yeah. After HIFU, we give the Gnrh and Gnrh for post-HIFU treatment. So this is the post-HIFU follow-up view. So after 2 months of follow-up, the ultrasound showed the adenomyosis size shrink to 3.6 to 4.5 centimeter, with the size reduction rate about 75%. So the summary of my surgical video talk is HIFU use the characteristic of ultrasound to penetrate tissue, and the high intensity ultrasound can treat internal mass without injury to skin or uterine surface. So it can achieve the real non-invasive surgery. And for the myoma treatment of HIFU, we usually use concentrated high dose energy strategy to treat the central 3 large phase to produce a core of the coagulation of necrosis. And then after the core of coagulation necrosis was produced, we can put energy around the core to make the core occupy the whole myoma. For adenomyosis of HIFU treatment, we should protect the endometrium with a safe margin. So we consider average low dose energy strategy to put the low dose energy to hold the whole adenomyosis, and then after put the whole adenomyosis, we can use Doppler ultrasound to see if there is still any residual blood flow inside the adenomyosis. Then if there is still flow, we can make individual reinforcement of energy to those residual flow sites. So thanks for attention. Yeah, thanks for APAGE to give me a chance to have talk here. If any question, welcome to email me. Thank you.
Thank you, Dr. Chen. Very interesting and engaging talk. We have a lot of questions in the chat box. Apparently, your talk has generated a lot of interest in our audience. So I'd like to read the question. We have time to have a Q&A. So the first is from Dr. Olaric. For adenomyosis, do you use medications such as Gnrh agonist or Dienogest plus HIFU? I think it was in one of your slides. Dr. Chen, kindly answer.
Yeah, I usually use I use Gnrh agonist or Visam after HIFU, because like just Professor Chen said, yeah, after HIFU treatment, we still cannot confirm is there every adenomyosis cell can be treated by HIFU. So I usually use Gnrh after HIFU to give the possible residual adenomyosis cell treatment. And the Visam and the Dienogest I also use for a maintenance treatment. Yeah.
Well,
okay.
Thank you. So from Dr. Matepan, in the treatment cycle for adenomyosis, I suppose that's a HIFU treatment. Is it necessary that you should avoid treatment during the menstrual phase?
Okay. Oh, and sometimes because sometimes the patients may have prolonged menstruation or prolonged spotting due to adenomyosis. So it is hard to prevent HIFU performed not in breathing time. So we usually said we can perform HIFU during menstruation, but we need to avoid the most largest amount stay. Yeah. If the menstruation is a little bit, that is okay.
Okay, maybe at the end of the menstrual cycle, right? So another from Dr. Ala Weiss, can we treat a huge myoma, meaning larger than 12 by 12 centimeter? So do we have limits, Dr. Chen, for the size?
Yeah, the size is not an issue because I will check if the the huge myoma is over umbilicus. The HIFU usually need to avoid the acoustic channel to pass away the umbilicus, because the umbilicus is easy to have burn injury. So if the myoma is over the umbilicus, we may need we need some medication like Gnrh to make the myoma and shrink below the umbilicus. Then we can treat it. So the size is not really an issue.
Okay.
Of course, there is some papers said when myoma over 10 centimeter, it may have much more risk to like bowel injury or nerve injury or tumor lysis syndrome during ablation. But in our center, we have not made such problem. Yeah.
Okay, thank you. This is from Professor Tsutsumi Osamu. Your hospital is very famous. I think that's Jianggung for laparoscopic surgery. Is there any guideline for indication between laparoscopic myomectomy or HIFU? I mean, how do you choose the cases? Which one goes to HIFU and which one goes to laparoscopy? Dr. Chen.
Yeah, because the HIFU has very high cost in Taiwan. So if people, sometimes we need to see if the patient's insurance, if the patient can afford HIFU, and I will give a choice.
Depend on the patient, maybe.
It depends on the patient.
Choice of the patient, maybe.
Yeah, if patient want HIFU, I will see is there any is any contraindication to these patients. Yeah.
Thank you.
Thank you. Another, so your talk is very engaging for our audience, from Dr. Ailey about for adenomyosis. Maybe you should confirm because of the uniqueness of the disease. We usually use 3 steps. I think this is a commentary. You first use HIFU, then Gnrh or the Unogest. The third, and maybe the third option is TCRE plus Mirena. So that may be just a commentary. Here's one question from the Philippines, from my colleague, Dr. Karin Reforma. What's the recurrence rate of adenomyosis myoma after HIFU treatment? Dr. Chen, please.
Okay, for our experience, we can see the HIFU treatment. If the recurrence rate means the mass get re-enlarged after HIFU, yeah, we can see there almost about 10% recurrence rate after HIFU. Of course, in this patient with recurrence, we can see their mass sometimes is much bigger than other without recurrence. So we still need to, when we choose patient for HIFU, we still need to, if the mass is much bigger, or if the mass has much more buffer, and we need to use some medication before HIFU to make the mass shrink or endovascular and shrink, and then we treat the HIFU, and we use the HIFU to treat. That may make much more good response, better response.
Okay, so thank you, Dr. Chen. I guess that was the last question. Congratulations for your talk, and I will turn over the floor to our chairman, Dr. Tsutsumi Osamu, for the closing remarks. Professor Osamu?
Yeah, thank you, Angela. Before closing, I would like to thank all the speakers and participants for joining the wonderful, fruitful international meeting. I hope this meeting make a milestone for dissemination of HIFU all over the world. And finally, I am going to remind you third episode. Will you please keep the date? Okay. So thank you very much and see you soon. Thank you.
Thank you.